Hello and welcome. So in this lecture, we will talk about a very specific topic in maternal medicine, which is multiple sclerosis with pregnancy. It's one of the neurological topics, not so common, but it's one of the topics that we really have to cover. So we'll try to make it as simple as possible. So let's get started. So first thing, why we're actually talking about multiple sclerosis in pregnancy. We know it's a CNS disease, it's a neurological disease, it's basically related to demyelination pathology, basically. We're talking about it because actually it's more common in women. It's 2 to 3 times more common in women than men. And the peak age of it is around the age of 30s, which is actually the age we expect women probably being pregnant at this age group. So it's really coincidental with the patients that we typically see in obstetrics. The incidence is 1 in 300, which is, it's not that rare. It's not as rare as we would think about this type of disease. So we have to give some hints about the disease before we start. It's really hard to really go into the details of the disease and diagnosis, treatment of the kind of stuff, but we have to know some little things about it just to be able to understand what's coming and realize what as obstetricians have to do at the time of pregnancy. So basically, there are 3 types of multiple sclerosis that we see. The first one is a relapsing remitting multiple sclerosis. This is 85%, so that's the most common type. And as the name says, it's basically that the disease is coming and going. So periods of relapse and periods of remission. This is how the disease goes. There is another form, which is actually not that common. It's called secondary progressive disease. And as the name says here, it's progressive, which means it's not coming and going. It just keeps getting worse. And it's secondary because it comes after a period of relapsing and remitting. So it happens after the first type and not at the beginning. On the other side, the primary progressive multiple sclerosis is the second most common type. It's 10 to 15%. And basically, the disease just gets worse from the beginning. It never passes through the period of relapse and remission. It's from the beginning, and that's why we call it primary. It's from the beginning, progressive in nature. And just to be familiar with the EDSS, it's basically the Expanded Disability Status Scale. This is a scale that's commonly used in patients with multiple sclerosis to actually, describe the severity of the disease. So just to be aware of it, it's basically like a 20-point step. Each step is 0.5. So totally, it's from 0, which is absolutely normal, to 10, which is actually death related to multiple sclerosis. So the way it's obvious that going towards the number 10 is basically, indicates basically that the disease is more severe. And this is how we can interpret this scale. So the other thing we need to know is what are the typical symptoms of multiple sclerosis. And as said before, in epilepsy, you don't make the diagnosis, you don't diagnose patient with multiple sclerosis, but you have to be aware when you meet a patient with multiple sclerosis, what symptoms they typically suffer from. And of course, you're brilliant. Maybe if you notice some of these symptoms in a patient that's not known to have MS, you may have doubts that this needs to be reviewed by a neurologist. So basically what they describe, the most common symptom, there's so many symptoms, a wide range of symptoms related to MS, but some of them are more common than the others. And I would say probably the most common symptoms are those related to vision. So basically diplopia, blurring of vision, poor color vision, all these things related to vision are symptoms. The other symptoms are spasticity, it's one of the very annoying symptoms. And of course, numbness, tingling, prickling, these symptoms add as well. And in addition to that, those patients typically also describe urinary incontinence or urinary retention as urinary symptoms. Same for fecal incontinence. And obviously, there are complications that can happen based on these symptoms, because I mean, if they're having problems with emptying their bladders, they are prone to high risk of recurrent urinary tract infections. There is decreased bone density, and there may be some issues with breathing as well. So these are things to keep in mind. Okay, let's go to our side. I mean, the more interesting side of this lecture, which is basically we as obstetricians, what we need to do when we manage a patient with MS in pregnancy. So as I mentioned in epilepsy, it's the same thing. You need to just make it step by step. So ideally, there should be a stage 1, which is a preconception, stage 2, which is actual pregnancy and antenatal care, stage 3, which is management during labor, what you need to be aware of, and stage 4 is management after the baby is delivered. There is an extra information we'll mention here, which is actually related to infertility. So we'll keep it as a last thing, just few notes about infertility management on those patients. So first thing, preconception, I would just categorize our job into 3 main categories. I would say counseling, just speaking to the patient. I mean, the patient is worried about getting pregnant, what to expect in terms of pregnancy, in terms of the baby, in terms of the mother herself. And the second thing is basically what recommendations you should give before she gets pregnant. The third thing, as usual, is to review the medications, what's safe, what's not safe in pregnancy. So start with counseling. We know when we counsel patient, we basically speak about what to expect, what are the risks associated with MS and pregnancy. And when we say risks, typically we speak about the mother, the disease on one side, and the baby on the other side. So it's very important to mention to the patient that getting pregnant is not something bad or contraindicated. It's okay, and it shouldn't be any factor that will make her disease worse on the long run. So that's very important to highlight. The other thing, which is a good news, is we are expecting relapse to be less frequently happening in pregnancy for some reason. It's probably that immunosuppressive action of pregnancy that happens, maybe adds to this effect. And typically when we say relapse, we're expecting patient to experience like new symptoms that she didn't have before that are related to the MS. But has been said, there are certain symptoms that can get worse, and you can guess them actually, because these are the symptoms that happen in any pregnant woman. So we expect if the patient is having problems as a baseline, these symptoms will get worse. So these symptoms, you can make a guess. Definitely fatigue. This is happening with pregnancy. Definitely bladder and bowel symptoms. We know that women struggle with these symptoms in pregnancy. Back pain, of course. UTIs, of course. The other thing that you will tell the patient about is there could be higher risk of hospitalization if you're getting pregnant and you're having MS. And at the time of delivery, really depending on the severity of the disease, this can increase the possibility of a cesarean section or operative delivery. Really on those patients that are on the more severe edge, where they have like some motor disabilities or something that they can't really go easy with delivery. So these are some information that you would share with the patient just as a baseline to know what to expect in pregnancy. As regards to the baby, the good news is MS itself, it doesn't increase the risk of miscarriage, doesn't increase the risk of congenital anomalies, not like stillbirth, not prenatal death, is all good. The only risk that we can talk about is actually 2 things, which are very common among all medical disorders, to be honest, is preterm labor and fetal growth restriction. And even with fetal growth restriction, we're talking about like 1.7 times increased risk. So not huge, but has to be mentioned. Women like to ask about the chance of their babies having the same disease. And the good thing is, MS is not a hereditary disease. So the risk of their babies having MS is not like 0%, but it's very low. But if the mother already had a baby who has MS, then that's a different equation. So then the chance of another baby having MS will be 2.7%, which is still, I mean, it's not high, but you have to just set some expectations here. So this is the counseling part. How about the recommendations? What advices would you like to give to this lady before she gets pregnant? So two things actually. The first one is very common advice. Please don't get pregnant while your disease is not controlled. Advisable to plan for this pregnancy, to get pregnant while you are in remission and the disease is really under control. So this is a decision that's actually made between the three of you, the neurologist, and the patient, of course. So we always like to have a good plan for when is the ideal time for her to get pregnant. And again, contraception, very important in these patients. Still, it's appropriate to plan for pregnancy. The second advice, smoking. Please know, smoking really increases the risk of disease progression. So at least this is one preventable risk factors that we can work on. Stop smoking. How about medications? This is probably the most interesting part. So we have to be aware of the medications. We are working with a neurologist. As we said, we're not prescribing medications. We're not stopping medications on our own. We just speak to the neurologist to tell what is safe, what's not safe, what is okay if it's really indicated and so. So the good thing, two common medications that we typically use in multiple sclerosis are, I would say, safe in pregnancy. I mean, relatively safe. So it's okay for the patient to be on these two medications. And these two medications are the Copaxone and the interference. So absolutely okay to be on these two medications if indicated. There's a group of medications we know called DMTs, or disease-modifying therapies or treatment. One of the most famous probably is natalizumab. And this medication is, actually there's like a group of medication, but this one in particular is the most, or like the safest that we know to be used in pregnancy. So very important to highlight this. Typically, DMTs are not mandatory for patients with multiple sclerosis. I mean, they should be suggested for those who really have an active disease, a disease that's hard to get under control. And this is a neurologist decision, as we mentioned. So if he or she thinks that the disease is not under control or a highly active disease, that the patient needs to be on DMTs, then natalizumab is probably the best medication to be on. Other immunosuppressants, other DMTs, probably not. So there's one thing about this medication is basically we recommend, or we say it's safe, the patient can use it, but we would like to stop it at 34 weeks if possible. And the reason for that, we don't want her to be on this medication while she's getting close to the time of delivery, because we know it's associated with some hematological disorders, probably reversible, but still that can happen to the baby. And that's why we like to stop them at 34 weeks. Has been said, they should be restarted after delivery. Ideally, they should not be stopped more than 3 months to reduce the risk of relapse. So just try to start the medication within 8 to 12 weeks from the last dose you gave, which is probably around 34 weeks or less. And this is how you use this medication. But other medications, no. So typically we mentioned 3 medications that can be used safely at the time of pregnancy with certain precautions. This is a very nice figure about the therapies actually. And as you see, it's basically going from the first line therapy to the ones that are used when the disease is really highly active. So as you see, the first line medication is typically, as we mentioned, the Copaxone and the interference, and they are in the green box, which indicates that they are safe in pregnancy. All the medications in the red box, obviously not very safe in pregnancy. Natalizumab is in this violet box, which means basically it can be used with precautions and should be stopped at 34 weeks, as mentioned. So again, these are like the options, but definitely you need to work with a neurologist, because at certain points when it's really considerable or maybe life-threatening, I mean, they can say, okay, we think that at this stage we have to break the rules because of the safety of the mother. And we know always the priority is to the safety of the mother. Okay, so going to the second stage, which is actually taking care of the pregnant woman while she's already pregnant. Again, if you have made the checklist for the preconception, you met the lady, you did all what we mentioned, perfect. But if the patient came just pregnant, and this is the first time you meet her, you need to go through the checklist that we mentioned in the preconception stage as well. So during pregnancy, as with any other neurological disease, you work with a neurologist. So it's a multidisciplinary teamwork. And you want to be sure that she sees you and the neurologist at the same time. In this stage, you can give recommendations, you can give medications, and you need to do an assessment, or like a series of assessments as well for this particular lady. So let's go through this. Recommendations, straightforward. We mentioned that there are certain symptoms that are probably going to get worse for a pregnant lady. For example, fatigue, constipation, two things. And for fatigue, we always like to advise towards rest, not like bed rest, not like being in bed all the time, but just taking it easy, because we know that fatigue will be a problem. So just advice about rest, stress reduction, things like that. For constipation, absolutely, hydration, fibers. If laxatives are to be needed, that's fine. So you need to be more proactive with these two problems, expecting they are going to be worse than other pregnant ladies. So in terms of assessment, what do you need to do? It's actually straightforward. There's one thing that you need to do to the mother herself, or basically for the sake of the mother, which is to check a midstream urine sample every month. And this is particularly not necessarily for all patients, but with patients that have ongoing symptoms, urinary symptoms, or baseline urinary troubles related to the MS, because this is going to get worse, and they are more prone to that, to like urinary retention kind of thing, and they can get into UTIs without even noticing. It's a little bit tricky, because pregnant women, I mean, the way they feel symptoms of UTI can be a little bit tricky, and they may not give you really typical symptoms for it. And that's why we're trying to be more proactive, just doing the midstream urine check every month for this indication. The other thing, as we mentioned, 1.7 times increased risk of fetal growth restriction, which means that at the third trimester, just do a series of ultrasounds to check on fetal growth, be sure that everything looks okay. In the meanwhile, while she's pregnant, probably at the beginning of the third trimester, you can definitely arrange for an anesthesia review. The severity is different, and definitely you need to be sure that the anesthesia team meets the patient, just have a plan in place in case we have to go for a surgical management or anything. From our side, we always say nitrous oxide, the gas, is fine, Bethadine is fine, the transcutaneous electric nerve stimulation, fine, regional anesthesia, these all things should be safe in labor. The third thing is medications. And when I say medications here, we're not talking about reviewing the medications, we're talking about like extra medications that she may need. Basically, just be aware of the VTE risk in pregnancy, or venous thromboembolism risk in pregnancy, because if this lady has like some sort of motor disability, reduced mobility, she's always in bed, you should take that as one risk. And if there is any additional risk, then you're likely going to prescribe low molecular weight heparin. I mean, I'm not going to go through the whole VTE like prophylaxis, is a different lecture, but I would say basically just always count this as one risk. I mean, just be aware that if you think that she has any problem with mobility, that should be put in mind as one thing. The other thing, there are two problems that are pretty common in women with MS. As we mentioned earlier, spasticity and neurogenic pain. So the typical medications that we can use, and they are okay to be used in pregnancy, are diazepam for spasticity and amitriptyline for neurogenic pain. So that's okay. Working with a neurologist, you can say, fine, she can take these medications. There is one thing before we leave the antenatal care section, is basically what if the patient had a relapse? And when we say a relapse, it basically means that she has been really in remission, everything looked okay, no issues, and all of a sudden she starts having like active symptoms, new symptoms, things that look like related to the MS, and the MS is actually relapsing at this time. So that's actually something that you should keep in mind, especially in the first and second trimester. So both you and the neurologist should be really reviewing the symptoms, because especially in these 2 trimesters, because this is when you expect things could really happen. And as we know, and it's not you that you're doing this part, but you have to be aware that we have to use MRI basically to diagnose a relapse. And from your side, the only thing that you should mention, and pretty common in our practice, is to mention that gadolinium is a contrast that's used in MRI, is not recommended in pregnancy. There is a lot of debates and different lectures, I mean, about it, but basically we wouldn't recommend using gadolinium in MRI to start with. So if it happens that the patient is having a relapse, the typical management is oral or IV corticosteroids. That's fine. That's fine from our side. But the only thing you should be aware of, because this is your job, is if the patient had received treatment of relapse in the form of corticosteroids, which is probably a high dose, and this happened within 4 weeks of the time of delivery, that she is eligible for a stress dose steroids, which means basically there's like a different regimens, but typically you do hydrocortisone 100 milligram IV every 8 hours. So, and this is typically to protect against adrenal crisis, because, you know, if she has recently received a high dose of steroids, her adrenals may be not working that good. And at the time of labor, with the stresses and everything, like the whole thing can crash. So this is just to be aware of what if relapses happen, how we treat, how we diagnose, what we should be aware of. So let's go to the intrapartum management. So now she is in labor. Great. Okay. The first question, does it really matter if she's having MS? I mean, in terms of the mode of delivery, the time of delivery, does that change anything? Actually, the answer is typically no. She can just deliver like any other pregnant woman. If there is any change in plan, it's basically if there is an obstetric indication to it. However, as we mentioned with different other diseases, things are really getting like worse for some reason toward the end of pregnancy. And you're seeing like her EDSS, as we mentioned earlier, is getting really worse and worse, and it's not getting better for some reason. This is when we may consider induction of labor a little bit earlier. So that should be really a discussion amongst the team to decide. The other thing is some women really have like motor disabilities, significant ones, that you may have to really, you know, judge and think and see if they are severe enough that you don't think like a normal delivery or a vaginal delivery would be an option, and then you may consider a planned or elective C-section. That's one thing. The other thing, and your nurse should be really aware of that. So you, as I mentioned before, just speak to the team. If this is like, if you're dealing with a challenging case, unusual case, a case that your team hasn't been dealing with so frequent, just communicate with them of your thoughts. So basically, this lady is prone to neurological problems related to her bladder. Just be sure that bladder care is excellent, which means there's like periodic emptying of the bladder. You're emptying the bladder frequently and periodically. And definitely, I mean, and that makes sense, of course, that if she's having an epidural anesthesia, then consider just a Foley catheter in place. So don't just go in and out, just for peace of mind, just leave a Foley catheter in place, and that's it. And as we mentioned, there's always a chance of instrumental delivery because of exhaustion, because of fatigue. Basically, we do that. I mean, an instrumental delivery can be done for that particular reason, but I mean, just be aware that those patients are likely to really be fatigued and really to go through an extensive exhaustion kind of thing. And then you have to keep a low threshold of considering instrumental delivery. Postpartum, so good news, baby is delivered, we're happy. Definitely, as with any other postnatal care, you should have a plan in place with like the whole team involved that is set in the third trimester. So you're planning, you know what you're planning for. And basically this means if she's breastfeeding or not, definitely you need to know about that. If she's starting any medications, if she's stopping any medications, there should be a plan in place for that. And I would say, generally speaking, breastfeeding is fine. She can breastfeed, encourage her actually to breastfeed. If she's taking steroids, still can breastfeed, but there would be another like advice is basically if you're taking steroids, if you can just space it. So you breastfeed 4 hours at least after the administration of the steroids, it'll be much better. So you still can breastfeed, but just with some extra cautious. The other thing is if the patient is having a very active disease, we talked about that already, and we mentioned that natalizumab is the option to start, and it should be within 3 months of the last dose that she had. Typically, with DMTs, no breastfeeding. So we should be clear about that as well. The last thing is absolutely, as I mentioned before, contraception. Don't let the patient go away, leave the hospital. I mean, she is here in the hospital, you're the doctor, you're probably the best one to talk about contraception in these situations. Just do it. There's a lot of contraceptive options that can be just started, set up at the time of hospitalization after delivery. Because, you know, those patients, we don't want them to get pregnant unplanned and go through a lot of issues. Imagine this patient going just pregnant while she is having symptoms or the disease is really active. She didn't really have a plan for like medication stuff. So for this purpose, just be aware, mindful of this problem, and just be sure that you at least discuss with her what contraception she wants to go for. And it's easy choice because in MS, I would say probably most, if not all, contraceptive methods should be fine. This is one last thing we'll talk about is basically MS and infertility. And it's really not like a big deal. It's just a few information that it's good to be aware of. Is just set expectations. If you're treating a lady with infertility and there is a plan for ART, just be aware that those patients at higher risk of relapse, especially within 3 months after ART, the odds of them having relapses actually increase if you're using GnRH agonist protocol. So just be mindful of that. That one thing that you can actually try to avoid. Unsuccessful attempts, unfortunate. can increase risk of relapse as well. So just be prepared for that. And the reason why, as mentioned in the slide, there are like 3 theories about it. One of them is actually the stress related to treatment of infertility, especially if she knows that she's having a background problem. The other thing is many patients, they don't want to test the odds. They just discontinue the medications before going for ART, which can really aggravate this disease. And there are definitely some immunological changes that could contribute to this as well, related to the ART therapy. So I would say the take-home message is just be aware that if she's undergoing an ART treatment, just try to avoid some of these risks if possible, and just be ready to expect and just set expectations for the patient as well, that we need to keep an eye on things, not to increase her stress, of course, but just to be sure that there's like a good follow-up, basically, while she's undergoing an ART treatment. I would say that was basically it. Thank you. Again, I mean, this is not a very common situation that we typically treat, but it's very important to be mindful of these patients, because as I said, you can definitely meet one of patients with MS that is now pregnant. And at the same time, there are little things that really can, change the management and just make things easy for you, easy for your patient, and just, optimize the outcomes. Thank you for being here, and looking forward to meeting you on the next lecture.